Welcome, everyone. I'm Christy Newton. I'm co-facilitator of the TBC at UBC Network. I'm also the Associate Vice President Health Pro Tem and an Associate Professor in the Department of Family Practice in the Faculty of Medicine at UBC. And today I'm joined by Lee Yates, TBC at UBC Network co-facilitator, and also a clinical associate professor in UBC's midwifery program, also in the Department of Family Practice within the Faculty of Medicine at UBC. So thank you for joining our network event. We're really pleased to start up again in a new academic year. And before we dive into today's topic, I would like to do a land acknowledgement. And I acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of the Musqueam people. And the UBC Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to recognize that UBC's activities take place on Indigenous lands throughout British Columbia and beyond, and that you are joining us today from many places. And I acknowledge the traditional owners and caretakers of those lands. I am attending from Port Moody, which was originally referred to as Saymamit by the Tsleil-Waututh people. It is the traditional unceded shared territories of the Coast Salish people. Please feel free to share the lands from which you are joining in the chat, if you would like. So also before we dive in, we usually just give you a sense of what the TBC at UBC Network is. And so the TBC at UBC Network is supported by UBC Health, which works under the Office of the Vice President Health, to help address complex challenges affecting the health and well-being of individuals, communities, and societies. UBC Health facilitates collaborations across disciplines, faculties, external partners, and communities to improve the ways we train people, develop knowledge, and shape policy to ultimately address inequities and improve the systems that foster and support health. The TBC at UBC Network convenes health professionals and leaders, community members, academics, and policymakers right across sectors to bring forward questions and ideas important for team-based care in British Columbia. The network supports and complements province-wide efforts to enhance team-based care in British Columbia by focusing on education, research, evaluation, and knowledge translation, and by enabling participants to learn from each other and connect their efforts. And I'm now going to hand it over to Lee to talk more about today's session.
Thanks very much, Christy. Before I introduce our panelists and talk a little bit about what we'll be talking about and hearing about today, I'd like to begin with a poll. If everyone could take a moment to let us know which perspectives you are bringing into the conversation today, just so we all have a sense of who's in the room with us today. And I'm seeing a large majority, we're looking at 60 to 70% of the folks in the room are health professionals and clinicians. That's fantastic. We have a small number of people from our health professional associations, some UBC faculty and staff with us today, some health authority, health administrator, government folks in the room. Thank you. So in today's session, we want to focus on how innovation in team-based practice can help patients achieve remission of type 2 diabetes. Team-based care is a vital aspect in a growing body of evidence that remission of type 2 diabetes is possible in up to 50% of patients. Several professions fulfill collaborative roles in innovative team-based care practices across BC to support patients in their pursuit of type 2 diabetes remission. Today's session will be slightly different from previous sessions. We're going to start with our panelists giving brief presentations on how they've used team-based care to help patients achieve shared measurable goals and outcomes in type 2 diabetes remission. After the panel presentations, We'll be sharing some closing remarks, and then rather than moving into breakout rooms as we normally do, we're going to transition to a large group discussion. Please join us in conversation for as long as you're able to stay. We want to thank Sean McKelvey, the CEO of the Institute for Personalized Therapeutic Nutrition, for proposing this idea for TBC at UBC Network. And with that, I will pass over to Sean.
Thank you so much. As Lee mentioned, my name is Sean McKelvey. I am the CEO for the Institute for Personalized Therapeutic Nutrition. And we're an organization that focuses on using food therapeutically to treat, manage, reverse, or achieve remission of chronic medical conditions. And what I'm going to do is just a couple of minutes just going over who we are, a little bit about Remission, talk about team-based care, and then I'm going to hand it off to the practitioners who you're actually here to listen to. So just to start with, the IPTN is a registered Canadian charity, and our position is being diet neutral. We're funded through donations, grants, and our training revenue. We do not accept any funding from for-profit companies or industry sponsors. Our training is set up to promote an interprofessional team-based model. And one of the things that we really want to get across today is that therapeutic nutrition does require clinical oversight. And with our approach, which is really around, delivering clinical outcomes using evidence-based approaches, we want healthcare professionals to be comfortable that this is an emerging area of practice that really requires their attention. One of the main reasons that we want healthcare professionals to be aware of therapeutic nutrition and the different approaches to achieving remission of type 2 diabetes and other chronic medical conditions is the effect that they have on the medications. And if we don't quickly reduce or eliminate some of these medications, it can lead to adverse events. So the thing about what you're going to hear today is you're going to hear a couple of different perspectives and a couple of different approaches to achieving remission. And one of the messages we want to get across is that remission is about personalizing the journey. It's working with patients who are interested in pursuing remission and really supporting them in that pursuit. The exciting thing for us is that therapeutic nutrition does provide new evidence-based approaches for patients to choose and for providers to explore as an option for their practices moving forward. And a lot of this actually has been around for a number of years, but the exciting thing in Canada is that Diabetes Canada actually recognized remission a little over, about a year ago now. And Canada is the first country in the world to actually acknowledge that remission was possible. So this sets up a real exciting opportunity for clinicians who are interested in exploring this further. And just so you know, the remission definitions, there's a couple of versions out there. Diabetes Canada decided to go with two, one that is focusing in on remission to pre-diabetes, which is hemoglobin A1C of less than 6.5, or remission to normal glucose concentration, which is a hemoglobin A1C of less than 6. The ADA, or American Diabetes Association, and the European Association for the Study of Diabetes, they established the criteria consensus document it's about 2 years ago now, which was hemoglobin A1C of less than 6.5. But all of these definitions have the same requirement that there are no glucose-lowering medications. So the person has to be off all glucose-lowering medications and have a pre-diabetes hemoglobin A1C. And so how does this relate to team-based care? Well, we actually think that team-based care is the ideal approach for delivering remission services. So if you look at this, this is a RACI responsibility matrix. So RACI stands for responsible, accountable, consulting, and informing. And so you can see here we've got a list of different healthcare professionals along the top and the different tasks. So there's 10 different tasks associated with implementing a therapeutic nutrition type intervention. But what I really wanted to point out was that even though there are a number of different healthcare professionals that are listed here, a number of the activities, so 4 out of the 10, can be done by pretty much any healthcare professional. So what this allows us to do is really maximize the scope of practice of different providers, and to accommodate the different types of practices that healthcare professionals are going to be involved in. And so just to highlight that, we want to really present the fact that this is a highly adaptable model. And you are going to hear from 2 completely different approaches. So the key here is that team-based approaches with remission are principle-based, and they're not prescriptive. So no one is going to force a team to work in a particular way. It's about leveraging scope of practice and improving access. And primary care is where I think the ultimate objective here is to have remission services available to every patient who wishes to pursue it. But with every new practice, it takes time for that to evolve. So the beauty of this type of approach, though, is that teamwork is actually not constrained by physical space or geography yet. So as we're starting to develop these practices, we can take advantage of different virtual providers. We can look at different options that exist. So whether it's under the same roof and co-located, so it could be a clinic or a hospital or a PCN type environment, or it's distributed. So you have a variety of different community providers that you are tapping into depending upon what services are required. As I say, it could be virtual team members, or it could be completely outsourced. So there's a highly adaptable way to be able to ensure that patients have access to remission-based services. And for healthcare professionals who are just wanting to learn more about this, wanted to highlight that we have a conference that's coming up in about 2.5 weeks, that this conference is focusing in on the complexities of implementing therapeutic nutrition types of interventions for type 2 diabetes remission. You can actually get more information at the UBC CPD website, so www.ubccpd.ca. If you just search for remission, that's probably the quickest and easiest way to get it there. And registration is open, obviously, so it'd be great if you could join us. But it's an opportunity to hear from some of the top professionals. So we have Roy Taylor, for example, who was the first researcher to identify that remission for type 2 diabetes was possible. And he was the one that set the standard of close to 50% of the participants in the study that he was overseeing. They were able to achieve and maintain remission for a year, and he now has 5-year data. So up to 1/3 of those participants can still achieve remission. And then the other piece I wanted to leave you with is that if you're looking for resources and tools for patients, we launched a remission website last year. At the end of 2022, it includes a 24-page ebook. It has a readiness checklist. It has a prescription for better blood sugars infographic. There's a Q&A section. There's also success stories, which are very motivating. And there's also a letter to healthcare professionals. So for the public, if they're interested in pursuing remission, they can actually take this letter in and have a discussion with healthcare professionals about their interest in moving forward. And the great thing is that for those people who are part of the divisions of family practice, the website is actually a resource in the BC Pathways website. So I'm not going to take any more of your time, but I just wanted to do a quick intro, kind of connect the remission and team-based care, and just let you know that there are more resources and training and content available for those who are interested in learning more. So I'm going to stop here. So I'm going to end my slideshow. And what I will do is pass it over to Jasdeep, I believe, who is going to be the next. So Dr. Jasdeep Saluja is doing amazing work in Victoria, and I'm excited to hear some of the great team-based work that he is involved in.
All right. Thank you, Sean, and UBC Team-Based Care Network for inviting us, myself and Mark Daniel, here to present and have a conversation with everybody. Quite excited. My name is Jasdeep Saluja. I am the co-founder of Aroga Lifestyle Medicine. I also serve as the Chief Medical Officer. I'm in Victoria, the unceded territory of the Lekwungen people, Esquimalt, Songhees, and Wasanich nations as well. So I thought I would just kind of start, for a second, spend a little bit of time on, what's lifestyle medicine and my journey into it. So I started as an internal medicine specialist. I was in my residency, finishing up in 2012. And my father actually had a stroke in that same year, and had amazing treatment at the hospital. Had a CEA, was put on all the appropriate medications, and was kind of then let go from there. And nobody really talked to him about any lifestyle changes or anything else that we could do to kind of, from a risk reduction standpoint. And in 2015, he ended up having a myocardial infarction, so a heart attack. And I took him to the hospital that day. And again, he had amazing care in hospital, and got the appropriate treatment. And it was at that point in time when I started looking at, our lives and our health and our family history. He was the youngest of 5 brothers, and 2 of them had already passed on due to premature heart disease. I was looking at myself and my own cardiac risk, and started just looking at, is there anything else that we can do in addition to the invasive interventions and guideline directed medical therapy to kind of help reduce our risk. And that's kind of when I found out about, lifestyle medicine being a specialty through the American College of Lifestyle Medicine in the United States, where they focus on 6 pillars of lifestyle change, namely being optimizing nutrition, encouraging joyful movement or physical activity, optimizing sleep health, optimizing, stress management, social connectedness, and then working on avoidance of risky health behaviors such as alcohol and smoking. So really taking this research, started kind of, implementing it within our own lives. I was starting to eat healthier, do more activity. And as I was seeing patients at the hospital, at this time I had moved to Victoria, I was seeing patients in the hospital and doing the chest pain clinic and various other clinics. And normally when I would see patients, if they had high cholesterol or high blood sugars, we would talk about initiation of metformin and statin therapy. But I started to talk to patients about lifestyle factors that could be contributing to their current risks and risk factors and presentations, and started offering to work with patients if they wanted to make some changes to their diet, looking to get more joyful movement in their lives. And about half the patients in the hospital-based clinic were taking me up on these offers, and started working with them. And it was a lot of fun working with patients on lifestyle factors. About 6 months of me doing this in the hospital, one of my co-founders, Dr. Jess, who used to be head of division of internal medicine in Victoria, myself and him sat down for a lunch one day, and he started telling me about how he's been, really getting educated on lifestyle medicine and focusing on lifestyle factors with his patients as well. And that's when we had this discussion where we were talking about, as internists, as medical doctors, we have certain expertise in certain areas, and we can touch on, the evidence for making lifestyle change, but we really didn't have all of the skill set within one person to really help patients make, sustainable, long-lasting, significant changes. And we started talking about, trying to identify, what if we had registered dietitians? What if we had clinical counselors, health coaches, to really help patients make these transformational changes, and how the impact would be much greater than ourselves. And this is in keeping with a lot of the literature that comes out of the lifestyle medicine world, that when you're trying to work with patients on making lifestyle changes, it really is about working within a team, because all the team members, have different expertise that they can contribute to the patient's care. So in 2017, we actually started Aroga Lifestyle Medicine. It was a clinic based out in Victoria, where we were doing internal medicine, but our focus was really on helping patients make therapeutic, evidence-based lifestyle changes. And when we first started, this is sort of like just the patient flow that we had. So we would get a referral from either nurse practitioner, family physician, other specialists from the community. The referral would be either for some type of illness process in the cardiometabolic realm, so obesity management, diabetes management, primary prevention, secondary prevention, atrial fibrillation. Patients would then get a secure questionnaire sent to them that they would fill out, and that would include a lot of their medical history, but also looking at the six pillars of lifestyle change. That's when they'd come in for a consultation in person. This is in 2017, before everyone went virtual. They would see our registered dietitian as well as an internist. At that appointment, they would review labs that were done prior to the clinic appointment. We would look at assess their current clinical symptoms, make changes to medications or further investigations if necessary. But a lot of the appointment was regarding patient education, seeing where they were at in terms of their readiness for change. And we kind of follow the therapeutic model of change. So, are they pre-contemplative, contemplative, prepared, and ready to take action, that type of model. And then we would give them a bunch of patient resources that we had come up with, and then follow them, either initially when we first started, we would follow patients, 4 to 6 weeks out. But then we got quite busy. And so we had to really kind of focus in on how often we'd be able to see patients. As we were doing this type of work, within the first year or two, we started to realize that, the adding a registered dietitian with an internist was good from a team approach, and it was a great start. But we were identifying lots of areas where there were gaps in, the team-based approach, where patients who had, insomnia, weren't sleeping well, or PTSD, other trauma histories. And we weren't really, and we realized that if we don't help patients focus on those areas of their health journey, that these were areas that could start to become barriers to change and barriers to success. And so if we really wanted to have as many patients being successful, we really need to start building out the team. So over the last few years, what we've been doing at Aroga is really just building out our team. So from a specialist network, we've got we have physicians or internal medicine physicians that do a lot of the cardiometabolic consultations. We have family medicine specialists on our team that actually help with doing group medical visits. And we found group medical visits to be super helpful for patients who are trying to work on weight management, diabetes management. I think Brendan, does a lot of group medical visits, and I'm going to let him talk more about that. And we've got psychiatrists on team, as well as endocrinologists. We do have a sleep specialist that helps patients with insomnia management, as well as sleep apnea. And then on the non-physician part of the team, we have registered dietitians, clinical counselors, nurse practitioners, registered nurses, and cardiac technologists. I've listed a few of our group medical visits that we do. So we work on emotional resilience groups. We've got exercise and movement groups, smoking cessation, mindfulness, and meditation. We've actually added a couple of new groups this last year. We have a functional GI specialist who does IBS groups with our patients. And we also have a core lifestyle medicine group that's 8 weeks long that most of our patients get enrolled in after the initial consultation. And I thought I'd kind of just share a patient story to kind of walk through how, a typical one of our patients would be. And this is Tanya. Gave me permission to share her story with all of you. So I met Tanya back in 2019. She didn't have a family doctor like a lot of patients in BC right now. She was seen at a walk-in clinic and diagnosed with high blood pressure, high cholesterol, and diabetes. She was prescribed ramipril and metformin on that visit, and there was no follow-up scheduled. She had a consultation with a gynecologist for getting a hysterectomy for management of cramping and bleeding symptoms. And it was actually her gynecologist that referred her to us to help with some weight management prior to the surgery. And so we saw her in May of 2019, and we did initial consultation. We enrolled her in our group medical visit program. She started doing one-on-one with sessions with our dietitian. She was also seen by the sleep specialist. And so the brief kind of rundown of Tanya's journey. So back in 2019, one of the dietary patterns that, we talk about a lot is whole foods. You can call it plant-based or high fiber or plant predominant. So that's something that she started working on. Later in the year, she stopped her diabetes medications. She had her hysterectomy. By the fall of 2019, she actually had stopped her Ramapro. 2020, she was reassessed for her sleep apnea, and she no longer required her CPAP treatment. Overall, she's lost about 65 pounds, and as she has maintained it over the last couple of years, her diabetes does remain in remission. Her blood pressure is normotensive at this point in time. When I was talking to Tanya about wanting to share her story, she actually asked me about what I was going to share, and I kind of talked about how I'd go through what the aspects of the team that she had chatted with or worked with and her outcomes. And what she wanted me to make sure that was shared was that beyond her diabetes, beyond her blood pressure, beyond cholesterol or sleep apnea, what she found with the team-based approach was, it changed her life in terms of, they went from a family that would come home from work, have quick dinner, watch TV for a couple of hours, go to bed, and then do the same thing the next day, to a family that routinely does 50 kilometers of biking a week, having more fun together. Her relationship with her husband and her daughter are the best they've ever been. And so I guess the impact that sometimes as physicians and clinicians, we look at these hard outcomes of diabetes remission and blood pressure, hypertension, secondary prevention. But from a patient perspective, team-based care can actually be life-changing. To really, what's more important to them is that they get to participate in their life in a more meaningful way that's meaningful to them, in whatever that way they may mean, right? And then before we started today, Ben had asked us to kind of reflect on, what team-based care, what we've learned from it as individual clinicians. And so I think the key aspects of team-based care, we go from patients that we get to have more people contribute to the patient's care, and patients get access to more expertise, and they actually get to see how working on various areas in their health journey actually affect the rest of their areas in their health journey. I think for practitioners, professionals, doctors, allied health professionals, it is way more fun to practice this way, because we're actually, feeding off our team members' energy, and we actually get to learn. I learn from our clinical counselors. I learn from our dietitians. They learn from us. It's back and forth, and it's actually more effective care in that way, as least we've seen it. But we've really started to now dive into our data analysis, and from an outcomes perspective, they're not quite ready to be presented, but there's some exciting themes that are coming out of that. We're looking at, in terms of some of the biggest drops in A1C, is really based on, a lot of it is how often patients interact with any team member. It doesn't even matter which team member, but how often they're interacting. We've seen bigger drops in that, and we'll be presenting that in a few months as well. And I was going to turn it to Mark Daniel, who is a registered professional counselor working at Aroga and contributing to our patients as well.
Hi, everyone. Mark Daniel here from Aroga, Vancouver. First, I would like to acknowledge that Aroga, Vancouver is situated on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So I'd like to start off with a question for everyone. As a physician, I can't help someone change their behavior until they are ready to change. Is this true or false? Just hold that thought in your mind. So in theory, traditional approaches to healthcare would deem that to be true. Change does, in fact, begin with a patient's desire to do something about their circumstance. But that said, it's a misconception that we actually cannot assist with a patient's change process prior to them reaching that state of desire. So one question that we as healthcare professionals can ask ourselves is, what is getting in the way of a patient's desire to change? Are they getting in their own way? And if so, why? So that brings us to the value of team-based care and those approaches. So working collaboratively can kind of help us understand their experience a bit more deeply, and having access to different types of health treatments, help us identify the most effective questions to ask to help them make a change. And that's our goal, their change and their healing. So as you all know, the daily management of cardiometabolic conditions like type 2 diabetes is extremely challenging. And what's often forgotten in that shuffle is how frequent and impactful the mental health comorbidities are. As you can see on the slide, people living with diabetes are 1.4 to 3 times more likely to develop depression. And, you can see that it says 15 to 20% of diabetes patients suffer from depression. So if, we're talking about nearly 6 million people in Canada who suffer from diabetes, that's over 1 million people in our country alone who suffer from diabetes-related depression. Here's how team-based care can help. Through the access to things like mental health treatment and therapy, patients can reflect, and in reflection, they can kind of identify their unmet needs. And what this does is it kind of allows them to bridge the gap between where they are currently and where they would like to be. And we do this through encouraging emotional granularity. So that's like, how do I define this emotion? Emotional awareness, which is, what am I feeling right now? Self-acceptance. It's okay to feel this way. Values-based living, which is, what really matters to me. And of course, curiosity, which is, what is this teaching me? What lesson am I here to learn? So at Aroga, we develop these skills through a blend of psychoeducation, acceptance and commitment therapy techniques, mindfulness approaches, and positive psychology with an emphasis on positive. I emphasize positive because there's this huge power in positivity. We see patients living with type 2 diabetes, and they're much more prone to self-judgment. There's a bidirectional relationship between type 2 diabetes and major depressive disorder. So just as you see, type 2 diabetes increases the risk for depression, major depressive disorder also signals an increased risk of onset type 2 diabetes. It's sort of this really tragic, chicken or the egg type of situation. So that begs the question, how do we stop this cycle? We work on stopping the cycle by encouraging self-compassion. We encourage strength reflection through strength-based therapy, and we encourage the practice of gratitude, and we enable the development of resilience. So to nobody's surprise, we see this major connection between improved mental health in therapeutic engagements and, the management of chronic disease. So if we can learn anything from doctors like Gabor Mate, we must not only accept, but, emphasize that there's this need to prioritize emotional well-being as part of our medical treatment process. So behavior change, what is it really about at the end of the day? A big part of effective behavior change is applying this team mentality, collaborating to better understand the patient's experience from every possible angle, helping them get to a place of understanding about their diagnosis and relating that understanding to their needs. So, as healthcare professionals, we have to get in touch with the why, not just the what or the how. And we have to help them feel all the emotions they're feeling, and especially encouraging the positive ones. There's this growing body of research on diabetes mortality that shows when you help people develop kindness and joy and generosity and enthusiasm, people that display characteristics like this have a higher likelihood of positive outcomes. They live healthier lives, and they have a higher quality of life. And, ultimately at Aroga, and hopefully with all medical care professionals, that's our hope with patients, giving them a higher quality of life. So, yeah, thank you.
Excellent. Thanks, Jazz. Thanks, Mark. I'm Byrne, and I'm going to be presenting with Jess Pirnak from LifestyleRx, and I'm presenting from the unceded traditional territory of the Semiahmoo Nation here in White Rock. So I'm going to jump into our deck and then kind of present an overview. Okay, there we go. So what we're trying to do is we're trying to deliver type 2 diabetes remissions virtually at no cost to patients with provincial healthcare coverage. And everybody knows these statistics, but they really are stunning. Kind of 1 in 3 North Americans have prediabetes or diabetes, and it's consuming a huge part of our economy. The graph kind of just keeps going, right? And it's gone up from a prevalence of less than 2% to 11% today and continues to climb. But we know that this doesn't have to be the case. So back when I graduated from medical school, some of the first long-term remission studies in bariatric surgery came out. So in 1992, we see that somewhere around 70% of patients with bariatric surgery who have type 2 diabetes can have a lasting remission. More recently, and probably more impactful for my career, was back in 2018, a couple of therapeutic nutrition trials, the DIRECT trial, Roy Taylor, Mike Lean's work, and using a very low calorie diet approach, and Dr. Sarah Hallberg's work, the University of Indiana and Verda, with a very low carb diet approach, both showing about 50 to 60% remission, a little bit different criteria for that. But really kind of, what it showed us was that remission is possible, and you don't really need bariatric surgery necessarily for that. So when we look at this, we actually kind of look at it and say, the remission is possible, but not all type 2 diabetics are the same. And in fact, when we see people, we see that there are 5 different subtypes. And when we look at these subtypes, there are distinctions to be drawn. And it's very important that we do this as physicians in terms of assessing who can kind of achieve remission. And so what we see is, broadly speaking, you can take the 5, divide it, into 2 categories where there's either insulin deficiency as the primary issue, in which case remission's probably not in the cards, or insulin resistance, where lasting and durable remission is very much possible. And we know from the research, and especially some of the research that's come out in the last few years, that it's all about the weight, right? So it's hepatic fat that's driving a lot of this insulin resistance. And if we can lose significant amount of weight, and I think what DIRECT really taught us was it's about 15% weight loss for most people to get rid of the insulin resistance. And so this is really something that I think it needs to be, we need to be aware of, and it's something that we need to be pursuing. So when we look at this, you could kind of look and say, of the 100% of type 2 diabetics, there's probably 76% where remission is possible. When we actually look at our own data, what we actually see is that about 91% of patients have significant insulin resistance that, if resolved, would lead to A1Cs of under 6.5%. So this would really be, game changing if we could do this. And so one of the things that we've noticed as well, kind of looking at that broader population, while not all type 2 diabetes is going to be reversible and not all patients can achieve remission, everyone actually can benefit from the lifestyle changes. And so really what we want to try to do is help patients by, losing fat and losing the fat in the liver to restore the balance between their pancreas function and their insulin resistance. And that's what it's going to take to reverse diabetes and achieve remission. What we've done at LifestyleRx is come up with what we call kind of a full stack virtual approach. And essentially what we do is combine physician visits and consultations with an online curriculum and group medical visits. So patients get a personalized approach. They get expert guidance from physicians as well as registered dietitians. And we do that with the community support of patients supporting themselves. And we do this around a strategy that we call 4+2, but really essentially it's a nutritional strategy, an exercise strategy, a strategy to help people with metabolic flexibility to be able to burn fat, and then a recognition that stress and sleep play a huge role in type 2 diabetes. And we coach on every aspect of this. One of the ways to think about kind of the approach is instead of bricks and mortar, what we've actually done is use clinic overhead to fund educational tools for patients. So we've got a whole online curriculum that patients can pace themselves through, personalized reports where we actually take patient data and we show them, using their own data, exactly what's happening and explain kind of why they've developed type 2 diabetes and whether remission is possible. So we really take a lot of time to explain the why and understand the why. And then we get to the behaviors and focusing across nutrition, but also across exercise, sleep, stress, relationships, and purpose, and really help them to try to make changes where they can. The program, we start with an intensive 12 weeks. Every week has a different theme. So they're working online in their own curriculum at their own pace. So they can watch things a couple of times. And then they come onto a group medical visit where they have a physician, they'll have a registered dietitian, and they're able to ask questions. We kind of flip the classroom. The lectures happen at home. They come to the group for support. They come to ask questions. When things are going well, we celebrate. When things are not going so well, we try to figure out kind of what we can do to support them along this journey. In a way, kind of the way we work is inside the health system. So we get a referral from family doctors or from specialists, deliver the report, and then deliver back the care. So we're only tackling this one component around lifestyle approach to diabetes remission. And the amazing part of this is it really works. So this is some of our data, kind of 501 patients, 92% of patients improve A1Cs, 46% are in the remission range. And this is largely 12-week data. So we're really seeing kind of incredible improvements showing the power of lifestyle. The bigger things that I think you see, and Mark touched on this, is just, this changes people's lives, and it's transformative in terms of the person, the whole person, and not just the diabetes. And I think it's very impactful for both practitioners as well. So that's a little bit of kind of the medical model. And I'm just going to really touch quickly and turn it to Jess. We do have a change model. So when we look at things, there's the medical model around insulin resistance, which is incredibly important to be able to set the goals. But when we look at our change model, really kind of, it's TTP meets CBD, not CBD, CBT. And so this trans-theoretical model that Jazz touched on is really incredibly important. You need to know what stage somebody's at, whether they're pre-contemplation, contemplation, preparation, action, maintenance, or even relapse. And you need to gear kind of your approach to patients at each stage. And then when we look at the CBT tools, we see kind of a whole variety of tools that we have that we pair along to help patients. We call a patient journey their path, and we call the path when their habits align with their physiologies. And that's when good things happen. Program helps them find that path, but really staying on the path is probably the hard part. And so these tools kind of that we've developed and that we use from these techniques really help us help patients kind of frame their journey. And so, looking at process and outcome goals, helping people architect their lives, helping them break apart and understand what is happening with their habits, and then introducing tools that of our own, like the 20-mile march, all are kind of governed to help people across these two axes. And if we look at these two axes, there's obviously the insulin resistance, which I've detailed, but there is this readiness for change aspect. And when you kind of get progress on both sides, that's where you start to see the remission really being possible. And so the approach that we use, I think it's, we're doing it in BC, Alberta, and Ontario. We're doing it right now with physicians and registered dietitian. And I think that it's also open for clinical counselors. Probably the biggest challenge is just the fee schedule and the fee structures in terms of bringing others involved. So I'm going to kind of quickly turn that over to Jess, because Jess works with us, and I think it's really important to kind of how you work with a variety of physicians as a registered dietitian in a context where you have access to everyone in group, but not necessarily everyone on a one-on-one basis. How do you do that, Jess?
Yeah, and I think, so with these patients who come to us for 12 weeks, we do have 12 weeks with them, which I think is absolutely amazing. So they technically have 12 hours with a dietitian. So tons and tons of questions throughout those hour-long sessions regarding everything from what type of bread to choose and salad dressings to a little bit more complex things like, I can't even think off the top of my head, but a little bit more complex compared to general nutrition things. So, and they can choose if they are feeling overwhelmed or if they're feeling like they don't know what to prioritize, because the 12 weeks goes so quickly, right? So they kind of get inundated every week with more and more information. And for some people, that's very, very overwhelming very quickly. So I think it's nice that they have the option to work one-on-one with a dietitian to help prioritize basically what they need to focus on first. Or even if they have GI issues and we need to tackle constipation or diarrhea or acid reflux or IBS or IBD. And also I think sometimes if they're in a plateau or their blood sugars are still not where they want to be despite being in week 6 or in week 8. So I think having that one-on-one support with the dietitian is super, super important. So yeah, I would say what they can do is they can choose to work with one of us. There's 5 of us now, which is really nice. Anytime. So it could be before they even start the 12 weeks. It could be halfway through the 12 weeks. It can be after the 12 weeks, or even like 6 months later when they have finally decided they really need that extra support. So we see people throughout like the whole journey, which is really great. And they do commit to 3 sessions, which I think is really, really important, because sometimes a 1 session is not enough time, right? So it's, again, inundating them with tons of information. They get, 10 different things to work on. They won't do it. They won't like us. They won't come back. So I think kind of giving them 5 things, they work on it, come back, another 5 things, work on it, another 5 things. So anytime, and they have access to us. I would say the nice thing about having a team-based approach is with the dietitian, they do have an hour for that initial consult, and they do have 30 minutes with every follow-up. So we do have the leisure of a little bit more time with patients, which I think is such a great thing. And sometimes even the follow-up sessions, yes, nutrition is definitely the focus, but I think also we talk about sleep, we talk about stress, and anything else that's coming up for them that might be a barrier. So I think having the one-on-one care along with the physician, I think, is really critical. With the dietitian too, we're not being super prescriptive. It's really more of a coaching kind of relationship than it is an expert relationship. So what I mean by that is sometimes when you are an expert, you kind of come into these conversations with sort of an agenda or knowing what's right. So I think coming in with a coaching mentality, you're more of their partner and you're more brainstorming with them what needs to happen and troubleshooting if things aren't going well, and really building self-efficacy, because I think if they feel that they can do it, then they're motivated and you're kind of empowering them. So I would say that's probably what it's like to work with us one-on-one. Some of the challenges, unfortunately, we are free when they go through the 12-week program, but if they did want that one-on-one personalized touch, they are having to tap into their extended health benefits. So a lot of extended health benefits cover up to $500 worth of dietitian services, but some people don't have extended health benefits. And and I think the prescriptive model is sometimes hard for people, because even in the group settings, they want specific information, like how many carbs of X can I eat, and how many of this and how many of that. And we're really more about eating exactly what we just heard earlier about whole foods, mostly plants, not too much, and all the generalized recommendations versus these very prescriptive suggestions. So yeah, thank you.
I think when we look at it, so we place a huge emphasis on explaining why, and explaining why with the patient's individual data, and helping them understand kind of what's happening with their diabetes. The online curriculum teaches them what, and it teaches them what to do, and it teaches them a strategy. The magic honestly happens in the how to do it, right? In the group sessions, and especially the dietitians. I find the physicians, we're really good at the why and the what. We're not so good at the how level. Like we get prescriptive, right? Like that's just our nature, and kind of that expert approach. And I think the thing, from a team-based care approach that's really been awesome working with dietitians so closely, especially working with Jess, has been that kind of, okay, let's relax a little bit on the why and the what, and let's figure out how this person's going to make change. And even if that change is really small, if it's headed in the right direction, it counts, because we can build on that. And so that I think has been kind of one of the things I might not have predicted before we started down this journey. I think we'll turn it back to the moderator here.
As I mentioned earlier, we're approaching the discussion conversation part a little bit differently today, and we're going to transition from here directly into discussion in the whole room with those who are available to stay. Our panelists will be staying for the discussion as well. We recognize that folks may be drawn to the clinical aspects of today's presentations, and our hope with the TBC UBC network is to center conversations around team-based care from the lens of research, pedagogy, and innovation. So to start us off, I wonder about looking at the panelists, and I think we'll bring everybody into the room now. What have been the most rewarding aspects of providing type 2 diabetes remission services as a team? So this can be personal to you individually as clinicians, or what your team finds rewarding.
I can break the ice and jump in there. I think what's been unbelievable is just watching patients transform their lives. And Jazz had a patient story that was just indicative of what we see on a daily basis. A few weeks ago, I was out for a run in my neighborhood, and somebody jumped out of a pickup truck and ran up to me, which doesn't usually happen. But it was a woman that had done our program, and she wanted to shake my hand. And she had, and remember, we're all virtual, and she had lost 60 pounds in the program. She had this huge transformation, but she was just so profoundly affected. She had started in a walker, and she was now walking 6 miles a day, right? Like, it just, her life had changed. And her husband was kind of piping up in the background. He goes, "I've lost 25 pounds too. And, my family's healthier." And so this ripple that goes out from these changes, I never anticipated that. One of the internists that joined us in Ontario actually said to me after the first month, "Hey, this is why we went into med school, isn't it? Like, you actually feel like you're making people healthier." And we're not. We're guiding them. We're like Sherpas. They're climbing the mountain themselves. So that's for me, that's probably the most impactful thing.
Brendan, I'll follow that up. We had an experience at the Aroga Vancouver clinic the other day where we were sitting around in the lunchroom, I guess, and one of the patient progress reports came up, and we were just being able to share different angles of our experience with the patient and our appreciation for the progress that they had made. And there's something to be said about how rewarding it is to watch a patient progress, but then there's an elevated element of that when you're doing it collaboratively with others, because you're almost being supportive of them, they're being supportive of you, and being able to share in that there's this increased motivation to help. And I don't think I could achieve that as an individual practitioner, that level of desire to help make a change in patients' lives. So team-based care not only helps the patients be better in a more effective way, but it also helps us as practitioners be more motivated and stay at the top of our games, because we're getting support and we're being able to revel and experience all this joy that our other practitioners are feeling as well. So it's kind of like a win-win on both sides.
I was going to say, Jasdeep, I actually wrote down that you said it's more fun, and I put an exclamation mark after it as well.
Yeah, no, for sure. It really is. I guess from my perspective, one of the things that, Brendan mentioned, as doctors, we're so used to, being prescriptive. So when I first started doing lifestyle medicine, I just switched what I was prescribing. And it was interesting. There were people who were coming to the office ready for that prescription. And for them, they're like, "Oh, this is amazing. Thank you." And then there was others who were not ready for that prescription. They're like, "This sucks. You suck. You don't know what you're talking about." And I had to really learn. And in one of the lifestyle textbooks that I recommend to people all the time is called Lifestyle Medicine Handbook, written by Dr. Beth Frades at Harvard. And in it, she talks about really, as lifestyle, when you're trying to practice lifestyle medicine, you really have to take your physician or hat, turban, whatever, off, and really put on the health coach hat, right? And the health coach mentality is very different. It's so counterintuitive to everything I've believed and thought and taught and been taught as in our path. But that's doing that health coach sort of learning and connecting with patients. You actually connect with people at a level that I didn't think we were actually going to be able to as physicians, and that's a humbling connection, and it helps really kind of solidify your connection with the community that we all serve, right? The communities that we serve in. So that's been a positive for me.
That's great. So I've heard there's more learning, it's more rewarding, the care is more effective. You actually get that deeper experience with that or deeper understanding of the lived experience of the patient. So lots of bonuses of team-based care, it sounds, to both providers and patients. So I'm going to move us to the next question, and that is, so we've said this is great, everybody should do it. So what advice would you have for other teams or individual practitioners perhaps wanting to provide this type of type 2 diabetes remission care to their community?
So maybe I'll jump in there, because I feel in medical practices, one of the challenges has been around how do you, who pays for the team, right? How are the team paid for, right? And Jazz kind of alluded to it, but I think it's probably clear, or should make it clear, is that Jazz and his team are paying it out of physician fees. They're actually paying for a lot of that dietitian time, as we are at LifestyleRx. We're actually taking them from kind of physician fees and kind of, using kind of overhead to pay to bring the team in. So that's kind of an amount of commitment that and value that we see, is we're actually, paying for it out of other funds. So that's a challenge. And I think it's the elephant in the room with this. We're looking at the same kind of thing, bringing clinical counselors into kind of the approach, because there's a huge benefit there. It's just trying to figure out how to do that within the structures. And so that would be kind of a piece that I just wanted to draw some attention to. I think in terms of getting started with this, I think that, lifestyle medicine is a team sport, right? Like, it just, if you look across kind of nutrition and exercise and sleep and stress and relationships and purpose, I don't think there's a physician that can cover all those. I don't think there's a single practitioner that can cover all of those. So you really ultimately would benefit from a team. And so I think the more that we can figure out kind of how to innovate within the models and bring kind of teammates in is going to be our challenge.
Yeah, I mean, I would echo the same things that Brendan just talked about. But the other thing I would say is that teams come in all shapes and sizes and different forms, right? And I think it's going back to one of the initial slides I think that Sean kind of presented, is that team-based care does not have to be the same in Victoria or Vancouver or Salmon Arm or Ottawa or Toronto or wherever, right? I think it's really about focusing, on what are the local needs of the local community, what are the local resources, and how do we leverage, there may be people on the call or other doctors that can actually just leverage, a program like LifestyleRx, right? Like Brendan's, like it's fully virtual, that's pretty, and that's something that can accessible to everybody, right? And so what you've seen today, these are two different sort of examples of how we practice, and but I think there's probably room for many different types of teams, right? And the last thing is that team doesn't have to be all within one structural team, right? It can be like leveraging, looking at different people's practices. Like even within our city here, Victoria, we actually partner up with the atrial fibrillation clinic. We've partnered up with our GI clinic, to kind of work from there, right? So I think just it doesn't have to be one practice is taking on this team-based care, if that makes sense for a community, right?
I was just going to say really quick, just to add to the funding, I think encouraging people to take a peek at their extended health benefits too, because I think people just don't utilize them. So I think if you can point out where they can actually, take some money and use it, I think that would be helpful in the funding model.
We're also working with the Rural Coordination Center to start developing rural models, so that for communities that have different types of resources, we want to, back to the responsibility matrix, identify who can do what within the team. How do we leverage community resources? How do we identify additional providers that could be added virtually? How do you model that out? All those sorts of things will be worked on, but it requires initially some innovators, some kind of early adopters, people that believe in the approach, And then it's really focusing in on how do you do it for the rest of the province and scaling and those sorts of things. So I think we will collectively be tackling a lot of the challenges around what Brendan mentioned with team-based care and funding. And I think there will be a lot more focus because now we're seeing these kinds of models evolve, and the impact on patient care is so profound. And to the question of why do we do this stuff, prior to actually seeing patients going into remission as a pharmacist, because that's my profession, I never had a single patient cry on my shoulder. After, I've had multiple patients crying on my shoulder saying that it changed their lives and they feel like they're reborn. You can't buy that. You cannot, and you can't unsee it. When you see patients who have achieved remission, it's incredibly satisfying.
That's great. I'm just going to sort of highlight or draw out some of the things that I've heard so far. So the facilitators that I'm hearing are find workarounds with respect to compensation. Things like extended benefits, group visits, the divisions and primary care networks with their interprofessional teams, and where those funding pockets might exist, and look within your community, because each community may have, maybe a hospital foundation or different groups that may be able to support this, that sort of work with the resources that you have. So each team will be different. There's no set model. It works with your community needs and what you've got. Leverage technology for, non-co-located teams, and where you can find additional resources if you have gaps. I like the responsibility again, and looking for that responsibility matrix of who could do what. And not necessarily if you don't have somebody, that doesn't mean it doesn't get done. And the one thing that I didn't hear that I think is a really big facilitator is you each clearly have a passion for this. And I really do think that that's the starting point. And then pulling together like-minded people with a similar passion. But I think, you sell yourself short if you don't identify that one of the biggest facilitators of this is your commitment to find these workarounds and to develop these teams and resources for your communities. Okay, I don't know who was first. I saw a couple of hands, but I'll go with Brendan.
Just want to actually really add this from a lifestyle medicine standpoint. You can't forget the patient as part of the team. And when you do the group visits like we do, the patients, there's some extra factor, some X factor that emerges from these group visits. And I don't think I got it because I'm not a group person. And so I don't think I got it until a patient said to me, there's a patient who had finished. I don't think he turned his camera on once on the Zoom. I don't remember him talking. And he said, I'm really one of those guys that's quiet in the background. But when I heard people beating themselves up for things that weren't going well, I had such empathy for them. And all of a sudden, I realized I didn't have the same empathy for myself. And the group, that's what it unleashed for him, was he realized, I have to approach this a little differently, right? And so anyways, I think that there, from a lifestyle medicine standpoint, and if we want this to be sustainable, it's all about people helping people. And that the group format, if you haven't done group medical visits, there's something special that happens in them. And I think it's really just people actually helping each other.
That's great. At UBC Health, we have a unit within UBC Health, which is patient and community engagement. And this is it's empowering and engaging patients, and that peer-to-peer piece has been something that's come up in that group and how we're working with that. Great point. There is a question in the chat. Can the panelists speak to the exercise professionals that are used on their teams? Have they explored kinesiology, kinesiology students, which is similar to the Change BC program, which is in the Pacific Northwest Division. Do any of your teams have exercise professionals?
So I can comment on that a little bit. We've at Aroga, we've explored working with kinesiologists. Really, it's been a funding issue. It's about how we fund kinesiologists, because a lot of the insurance plans have coverage for physiotherapists, but they don't have coverage for the kinesiology part. At Aroga, we have one of our physicians is he's done exercise medicine himself as part of his sort of specialty in family medicine, and so we will get exercise consultations done by the physician, but we don't have a kinesiologist right now, and it's really it's a key part that we need, but it's one of those things we haven't figured out from a funding perspective just yet.
Yeah, and I can touch on that. So Wellness Garage, which was my physical clinic before LifestyleRx, we had exercise physiologists and kinesiologists. Funding absolutely was an issue in terms of people having to pay out of pocket for using the services. That being said, the value was really amazing, and so we're now looking at something that we'll probably launch in the new year, and it really kind of dovetail at the end of our 12-week program is actually doing some group work with a kinesiologist leading, basically teaching people around basic resistance exercise that they can do. But yeah, if again, kind of, without that elephant, if the elephant wasn't in the room and everything was accessible, you would absolutely have, exercise physiologists, kinesiologists, and potentially physiotherapists on the team as well.
I just wanted to, because I just realized, because we're talking about the elephant in the room, and just in case there are any policy people on the call here today, value-based care has been shown in multiple studies in the States to be one of the most cost-effective ways of doing care and team-based care. And for example, there was a study, and Brendan knows about this, with Dr. Dean Ornish, his cardiac rehab program in the States. They did a study with an insurance company, and they found that for every dollar spent on his program, which is led by all these team members, put $5 back into the pockets of the funder. Yeah. And you don't really see that type of economic outcome in medicine. And it's actually one of the reasons why his program is now covered by Medicare in the States. When we look at the States and we see that they don't cover much, but they do cover this cardiac rehab program, which is completely team-based, 72 hours of instruction, and it's free of charge because they see the value in that. So I think it's one of the things, like, how Brendan's team is putting out the research. I think the more research we can do, and then tie that in with economic research, I think will move things forward in this country.
Yeah, and type 2 diabetes is actually the it's the perfect condition to show value-based care in a brief period of time, because it's not the hospitalizations that I mean, the hospitalizations certainly do add up, but you can show it from medication cost reduction, so you can actually achieve it within a time frame that'll appear in your studies. It's actually one reason why LifestyleRx is launching in the US in 2024. And part of that is really that there are value-based care contracts that are available, and you can actually go demonstrate value-based care. And kind of one of our goals is actually to bring that back to Canada and show what can be done. I think I think that's the model. Again, if you look at the amount of money that's spent once somebody's A1C becomes abnormal, $30 billion a year in Canada, $300 billion a year in the US. If we take a small portion of that amount of money and fund all the team, we could have an amazing team be funded from the savings based on Remission. So we have to innovate, right? Like, we have to kind of push for these things, because it won't happen quickly enough. And every 3 minutes in Canada, another patient is diagnosed with type 2 diabetes. Think about that for a second, every 3 minutes.
I'm loving this conversation, and it's flagging a lot of parallels with conversations that we're having in maternity care around team-based care. Very similar interdisciplinary teams, a discrete period of time, and challenges, again, with the different models and remuneration and payment, and how to bring in some of the other care providers. And I love what you said around, local needs, local resources, what, the complement of providers in a community. And some of these questions are particularly important for rural contexts. And how do we leverage those? And I think about some of the, when I orient to, what we're hoping to bring forward through TBC at UBC Network, those questions around education, pedagogy, and research to influence, hopefully, policy and action. I think about, what are the conditions that we need at a policy level that would enable those local solutions, so the local people to develop local solutions under umbrellas like type 2 diabetes remission. And I'm not raising that to have the answers here, but flagging it as a potential inquiry question going forward as we're looking at teams doing this work.
One of the things I think also have to draw attention to is, we had a hands-on physical clinic during COVID, which was devastating for the lifestyle medicine clinic that we had. The silver lining was virtual care and actually diabetes remission delivered through virtual care. And from a rural access standpoint, if you look at the percentage of patients that we get, over 40% of our patients come from outside the Lower Mainland, and actually mirrors very much the kind of population dynamics. And so, virtual care and the technology there is available now. People, like everybody learned how to use it during COVID. So we have this little bit of a silver lining. It does equalize a lot. And the other thing we're seeing is our physicians are joining us from all over the place, right? So they're not like, it's again, so the notion of where people need to be can change a little bit. And there are some really innovative programs that are emerging, like what we're doing, like the CBT skills group, where you're getting kind of, access using virtual care. Obviously it's not, it doesn't replace primary care, right? And that's the thing, but for particular health jobs, it's actually incredibly well suited for that. Because I couldn't imagine people coming to our clinic for 12 weeks and sitting in a boardroom. Like it just wouldn't fly anymore, right? So anyways, I just thought throw that out from an access standpoint and thinking about it from a rural perspective.
Thanks, Brendan. Sean, go ahead.
I just want a comment and a question for Jasdeep and Brendan. So the comment really is that we're talking about type 2 diabetes remission, but we're really exposing the opportunity around metabolic health and the impact that can have, and the potential trickle-down effect that treating one condition can actually have positive impacts on so many others, whether we're talking about mental health, inflammatory conditions, GI problems, you name it. So I'd like Brendan and Jasdeep maybe to talk about all of the other types of conditions that they've seen improve as part of their practice. So again, we're talking about remission of type 2 diabetes as a potential focus, but it's way bigger than just type 2 diabetes and remission.
It's interesting. When we talk about, the pathways of inflammation and pathways of insulin resistance and how that affects, that shows up, it can show up as diabetes, but also shows up as non-alcoholic fatty liver disease. It also shows up as high cholesterol. It shows up as high blood pressure. It shows up as psoriatic arthritis. We're now having, more and more research showing that it's showing up as dementia, right? And so we're finding that a lot of these illnesses, while they have special, pathways, but they also kind of have some common pathways as well, right? And so the nice thing about doing team-based lifestyle medicine is that you're working to minimize a lot of the or address the common pathways that lead to all these illnesses. So oftentimes when we're working with someone for diabetes management, you will see, weight management, you'll see blood pressure issues come out, you'll see the cholesterol levels go down. Interesting thing is I learn new things all the time for patients. I'll be looking at them talking about the diabetes, and I'm like, so how's the last 6 weeks been? They're like, well, I used to have this rash. That rash is gone. I'm like, oh, okay, I didn't expect that. Oh, I used to have chronic pain. That's gone. That's getting better. I actually had patient drive down from Tofino to come see me, and I was seeing her virtually. And for her follow-up visit, she came in person. I was like, why'd you come in person? That's a long drive for you. And she's like, because I've been without pain for the last 2 months. I just wanted you to see that I'm not in pain and I'm getting up. And she got up and she did it. You know, she was like, almost like a dance in the office. Right. And so it's like, yes, there's a lot of other illnesses that we can address, but then there's like the things that we don't always think about. Right. And that is really affecting patients' quality of life.
Yeah. And I think that, type 2 diabetes is a great place to start, because already, a third of the population is actually, diabetic or pre-diabetic. If you went and measured insulin resistance, you'd be up around 60 to 70% of the population has some degree of insulin resistance. And that's really, we do need to address that. And one of the most common things that comes out in our groups is people will say at the end of it that what they learned in our group, they should have been taught in high school. Like, people really look at it at that level. And so, I think right now we've got an epidemic of type 2 diabetes, and there's a lot of people who are very sick that need our help. But if you back it up, we should be backing it up all the way to insulin resistance. I think the distinction of diabetes as being, if you look at kind of how we define diabetes, we only actually pay attention to diabetes once the pancreas begins to fail. It doesn't make any sense. We have patients that have severe insulin resistance that their pancreases never seem to fail. And yet they're suffering all the consequences of high inflammation, dyslipidemia, their increased rates for chronic kidney disease. And yet we're saying, oh, your A1C is 5.9. We're not really worried about it. Like, I think we've got to kind of change how we're viewing type 2 diabetes completely and frame it around insulin resistance, which I think actually starts to bring it into, what other things does insulin resistance cause? And then I think we'll really be dealing with like a true prevention program.
Brendan, that'd be a great study if we just started, doing, like, I know you do it and I do it. We do like fasting insulin levels and all that, but if we started doing like a study on, screening insulin resistance, right?
Yeah.
And seeing early addressing of that, right? Because like a lot of my patients with weight management don't have diabetes, but they have significant insulin resistance, right?
Yeah, I encourage anybody who's interested. The subtyping work that emerged since, I think it was originally in Sweden, but it's been replicated all over the world, and we're now doing it within our patients. And I kind of showed those slides around it. It's really interesting, right? Like, you see these different phenotypes of people, and the people with the super pancreas, and the people who have the pancreas that just doesn't work very well. And then the highest group there was the age-related, and what we see there is kind of the role of muscle. So again, back to bringing the physiologists and the kinesiologists into the team, muscle has a huge role to play. So anyways, I think there's a lot we could do by trying to change the discussion from being all around A1C to being around insulin resistance.
Denise, go ahead.
Congratulations for you guys present your work. It's amazing work. Not only about team-based care, but the way the patient can realize with just few changes in their life in terms of lifestyle, exercise, and what they are eating can make a difference. I'm wondering, what's in your program, what is specific to teach patients about medical literacy? Because patients right now, I live in a small community, in a remote community, and it seems like patients coming to looking for a doctor's appointment because they have some symptoms and want to exempt medication to get better at the symptoms. But the reality is we need to have the knowledge about the food, what you do, your exercise, your lifestyle. And do you have anything specific to educating patients about it's not only take a medicine, but it's a big stuff of it's a big life change commitment to make you feel better in life or lose weight. So I was wondering if you have anything towards medical literacy to teach patients about that.
So maybe I can start with that a little bit. Probably the most impactful thing we teach people is mindset, and we call it better mindset. So we, right from day one, we say, forget perfect, it doesn't exist. Your job is just to try to make better choices, and they can be really small improvements. Small improvements heading the right direction will add up, and that's a huge thing. We're fortunate that everybody that comes to our program actually has crossed the readiness for change piece. They actually have to do a fair bit to get into our program. So they have to register, and they have to do questionnaires and so on. Sometimes their patients, and many of our colleagues will be seeing patients who are kind of requesting the latest drugs and things like that. So the one thing I'll say, and just put this out there, is if you're prescribing semaglutide and you're not making specific recommendations around exercise and protein intake, you're doing your patients an incredible disservice. 40% of the weight loss from semaglutide comes from lean mass. And with healthy weight loss, we should expect no more than 15%, probably less than 10%. And so we're seeing patients losing a lot of muscle. And when they stop that semaglutide in a year or 18 months because they can't afford it or because of the side effects, they will not regain the muscle, right? And so I just feel really strongly that these drugs that are coming, there's semaglutide, and there's a whole pile of them coming down the pipeline. They're incredible tools for us as physicians. We've got to use them right. Like if we're just handing them out like candy because it's too hard to make some of these other changes, I think we're really doing our patients a disservice.
Thank you so much for your answer. And I just realized it's depending a lot of the community you live in, the location you live, because there is really a small and remote community, and they can have people, they don't have the education, or just having me only in the mind say, I'm just going to be better if I take a medication or if I have a doctor's appointment. So sometimes it's just they don't have the knowledge, and sometimes with the few times for the doctor to have the appointment, explain and educate the patient can take time, and this can have issues in terms of physician schedule. So thank you for that answer.
Part of, for me, what your question highlights is actually where are the various roles that physicians and the medical community at large actually need to be playing, right? So something like Brennan said, someone said, I wish I'd learned this in high school. I should have learned it earlier, right? And I think this is something in our current systems that we have set up, is that we train nurses and dietitians and physicians and, psychologists, counselors, and we put them into these various clinics. But we're the people who are supposed to be in charge of like helping facilitate health. Health doesn't happen in these clinics. Health happens every day at the store, on the playground, at home, in their relationships with their colleagues, all of that. And so it's like we gave us, all of us, everybody on this call has so much knowledge, but we're all just stuck in our clinics, right? And so I've been trying to advocate, even in our local communities, that when developers bring plans to the table for approval at city council, they should have someone from the medical health community sitting there saying, okay, do we have physical activity built in? Do we have, space for connection to be made amongst neighbors? The stores that you're going to bring in, are we going to create a food desert here? Or are we not going to create a food desert here? And so it's interesting, like lifestyle medicine, super gratifying, but at the same time, you start to highlight so many other things that we don't always think about when it comes to health. It basically keeps you busy. It keeps you up at night with lots of questions to grapple. But luckily I've got MD, who is my close friend, mentor, colleague, and I get to run these things by him and other colleagues and bug them all about it. And Sean gets to hear my rants every now and then too.
I actually think that's a great way to end it, because this is exactly what TBC at UBC Network is trying to facilitate, is these conversations, is how do we get to that place that we want to be, where and it's a complete cultural change, and it is needing to work across sectors in our communities, So thank you. And I think this has been great. It's continuing to stimulate thoughts for me. I'll go away and as you say, how can I model every day that health and wellness is a team sport, and it's not a pill. And at all levels of society, we need to keep championing that. So I thank our panelists so much for sharing. I think this has been great. And I really appreciate everybody's time. And so thank you. And thank you to all of those who are still with us. It has been very engaging.
Thank you, Sean. Thank you, Jasdeep, Mark Daniel, Brendan, and Jess, for sharing your inspiring work and journeys in team-based care with us today. I'd like to take a moment to remind everyone about our call for panelists for future network events. Being a TBC at UBC Network panelist gives you and your colleagues the opportunity to share learnings and explore emerging questions in your work to advance team-based practice, education, and research. If you're interested in being a panelist, please send us an expression of interest. There's a link, I think, coming up in the chat for that. I also encourage you to visit our new collaborative space for network members. We're really excited about this. You can provide your thoughts on what the network's next step should be and how together we can mobilize action. And again, there should be watch the chat. There should be a link coming up for that as well. Our next TBC at UBC Network event will be in January. We'll send out an invitation to all network members. If you're not signed up to the network, please do so at health.ubc.ca/TBC.